It is now time for our panel discussion. So we're going to have time for some questions at the end. So do get onto Slido and submit those. We will also have microphones going around the room. But the perk of Slido is you get to upvote the questions that are asked. So I would like you all to join me in welcoming our moderator for this session. And it is Michaela Regan, who is Policy and Engagement Manager at Lung Cancer Europe. So a warm welcome to her. And now I'd like to invite our esteemed panelists over on stage. So Penilla, we would like to invite you back. Thank you so much. We also have the pleasure of being joined by Kostas Syrigos, who is Professor of Medicine and Medical Oncology at National and Kapodistrian University of Athens. Thank you for being with us. Yeah, rounds of applause is good. We also have Mihai Rotaru, who is Director Market Access at FPS Surveys. Thanks for being with us. And Elena Petelos, who wears many hats, but today we are introducing her as Senior Researcher at the University of Crete and Lecturer at Maastricht University. Thank you all for being with us, and I'll hand it over to our moderator.
Thank you all for being here today. I'm sure you've noticed from the program that I am not Meadle. She wasn't feeling up to moderating today because she had a bit of an accident with her knee, but thank you so much anyway for allowing me to step in. So as Sarah said, I am the EU Policy and Engagement Manager at Lung Cancer Europe. And I'm very excited about our panel discussion today because I know that there, as Penilla has explained, is quite a disconnect between all the amazing initiatives going on at the EU level. You know, we've got a Biotech Act, we've got the AI Act, we've got the Cancer Mission and EU Beating Cancer Plan. But what does that really mean for people at the national level? You know, why should someone as a patient on the national level care about the EU initiatives? And I think we've got a great discussion coming today. So let me start off then with just asking everyone a quick opening question. So what, in your opinion, is the biggest gap between EU policies and a patient themselves? Why should they actually care about EU policies?
No, I think it depends on how your country has handled a European cancer plan and how they are involved in all these projects provided by Horizon and the opportunities to actually be part of that. We know it has created so many good collaborations all over Europe, but still there are, you know, some people, organizations, or governments that are not so active. And I really would encourage everyone here to ask, you know, more from their countries and the social minister or minister of health or whatever, department that are deciding this, because I think it's so important that it reaches out to patients.
Penilla described European Union as if something being above our heads and dropping asteroids that sooner or later will fall on our head. From the physicians and hospitals' point of view, I would say that this is more appropriate if we describe it being Brussels and European Union and European policies being far, far away from us. And in order to reach us, they have to cross mountains, oceans, the Persian Gulf, the Ukrainian war, and if we are lucky, hopefully we will never reach us. This is the way and the mistrust that exists between local way of doing things and European doing things. At the end, we know that what Brussels suggests is very good for our patients, and we know that we would like to implement that. But in the transition period, if we are forced to implement that, because, you know, European Union is notorious not having policies for implementations. There are no policies for implementations. The only policy, not only in health issues, everywhere, the only policy I'm aware of is many, many years after this was supposed to be implemented, to have a fine from the European Union that the government has to pay. That's it. So we know that this is good for our patients, but in the transition period, this means work overload for our staff, extra work for our staff, two systems that have to work in a parallel way until they merge to one, and this, for a very short period of time, is against the benefit of our patients in the everyday process. So there is, over these 30 years, a mistrust between these two administrative systems. And I think what falls between the gaps of this mistrust is the patient. Everybody does his work and get his salary. The victim of this gap is the patient.
So, excellent question for 9 a.m. on a Thursday, I would say. Been working on EU affairs for a number of years now. I don't think I've ever asked myself this question, so thank you for that. I would say, so I agree with the previous two interventions. I would say, just to keep it a little bit more cheerful, that it's maybe a function of size of the European Union. We are, at the end of the day, 450 million. And I would say that there are instances where we have to act as one, so that's the Europe. There are instances where we have to act as 27, and there are instances where we have to act as 450 million, and obviously there are subdivisions and steps in between. And I think that's, as Penilla was saying, the European Union is not an abstract thing, or at least that's how I understood that she wanted to say. I would say that the European Union, we are the European Union. At the end of the day, it's not really an abstract concept. I think you can very well make the leap of faith and imagine that it would be just a normal nation state with 450 million, and you would have the same challenges with the central structure, the regions, and then the individuals. So I think that's where, as Kostas was saying, maybe it's being lost in translation between what happens from the top down and what needs to happen from the bottom up. And by the time those two, let's say, ideas, or those two pressures, to call them, they meet in the middle, a number of years passed, and then everybody gets frustrated with what they had started from the bottom up versus the top down. That's maybe a little bit more of a philosophical answer. But I think that's how I see it as a reality, and at the end of the day, we all have to navigate our let's say, possibility of influence in between the steps, and we have to play our part in a certain way. And yeah, I think as it was said, unfortunately, time doesn't run as fast as we would like, but it is part, to a certain extent, of a democratic process. I'm not, I think what I'm trying to say is that it requires a little bit of patience, and we all don't have that patience, depending on the circumstances that we come in. But just to try to wrap it up as a first answer, this is, I think, the gap between the European level and then the individual patient level is this filtering that needs to take place in between. Because at the end of the day, we cannot do it on our own. It cannot be 450 million decisions on access, for example, or on risk-benefit assessment, for example. And then it's different decisions at different layers in the system that need to filter down until something robust comes at the end.
Thanks. I think in the interest of time, I'd like to keep it brief because we will have a chance to go deeper for HTA. I'd like to flag three things. The first one is I'm Greek. I've been abroad for 35 years. I choose to move to the Netherlands because between London and Oxford, I was feeling I was very far away from understanding what was happening to Brussels. And Brussels has changed how it legislates in terms of health. So in the last few years, with the European Health Data Space, with HTA regulation, which we will discuss, it has immediate implementation. It doesn't allow, as directives used to do, a lot of time for adaptation and so on. And this is something very new, and it affects all patients. And I like to say this also to my students: everybody is a patient or a carer, but it doesn't mean you can go into somebody else's shoes. And what has radically changed is, I think to some extent, I see sometimes patients more up to date in Brussels than doctors in a remote corner of a given country in Europe. The moment you start leaving Brussels, information starts to trickle down, become misinformation, become less relevant. So internet is an opportunity, digital means are an opportunity for participation and deliberation. And unfortunately, if you do not have citizen, people, patient participation with appropriate governance mechanisms, you may get policies that are very nice in terms of regulation, in European Commission English, not UK or US English, but which, when implementation comes, as Professor Syrigos mentioned, when implementation comes into play, translate in very different outcomes at individual, regional, and so on levels. So it's an imperative to know more, and I think this is why some of us, including myself, transition back to academia, because you have to bridge the information gap. It's the amount of information you heard to the AI Act, the EHDS Act, but there are actually over half a dozen that are intersecting, and they're written by different departments from different people, same as in a national government, sometimes not cross-talking. That is a very big challenge for patients, and it does impede access, and I think we will see a little bit more about that later on. Thanks.
Thank you all, and I'm really excited to see where this conversation goes, because it's nice to see that we've got, the policy perspective, we've got clinical, we've got academic, we've really got the industry. And actually, I think you set this up quite nicely to say, there are so many different aspects, and I think the EU HTA regulation is a great example, especially because yesterday in one of the talks, someone did mention that in some of the worst countries, it takes over 800 days to get access to a treatment. So starting maybe with Elena and Mihai, but please jump in, Penilla and Kostas. What do you think are the biggest barriers to things like we have the EU HTA? How do we make sure the patient in one country starts seeing more fast-tracked access to treatments? Like, what are these barriers, and how can patient organizations get involved to start tackling these barriers?
I think the most important barrier at the moment is that we are not one nation, unfortunately. Or for some others, fortunately, I don't know. This is a political issue. We have 27 governments that have their own agenda, their own priorities. Even if they are in good faith, something that I tend not to believe, but for the sake of the discussion, I put that option on the table. Even if they are in good faith, they request local data, local proof that this is useful for their citizens, which do not exist. So the first thing to do is to lobby not only in Brussels, but locally, in local governments as well. So to put all these issues in the priority list and in the agenda of local governments. This is very important. The second is to generate local data, and patients' organizations have a very crucial role in that. They can't do what other the governments or scientists don't do. The third obstacle is fragmentation. Let's take, for example, the screening program. Who doesn't is against a very well-organized European guided screening program in lung cancer? But in many countries, after early diagnosing lung tumor, there is no second step. The NHS, from country to country, the systems are completely different. And it's not easy to issue unique guidelines for all countries. In our last meeting in European Union, in the Parliament, I was very lucky to be invited by another loose event, I found out for the first time that European Union, that started as a European Committee, as a steel organization, blah, 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 has a common agriculture policy, has a common economical policy, now has a common defense policy, but does not have a common health policy. There are no, I cannot believe it. We are talking that we are democracies, and we are not interested for the health of our citizens, but we are interested in a hypothetical Star Wars from I don't know where. These are, or agriculture policy. Okay, but 90% of that is already outdated. So I think there are a lot of things to be done before we become one country. And I think health issues, health systems, is one of the most important. I will become a little personal as well. 2 days ago, this is coincident, I was visited in my clinic by a Greek citizen living over the last 30 years in Brussels, not in another remote city of the periphery of European Union, in Brussels. And he was 2.5 months ago diagnosed with lung cancer, symptomatic lung cancer. It was not screening. And he has not still started treatment because he could not make up his mind what to do. He had no insurance in Greece, so he had to pay everything out of his pocket. He had an insurance in Brussels, but then he would be alone because his family and all the supporting environment was in Greece. He was 1.5 years before retirement, and I was told, I don't know, that if he moved in Greece for good, he would lose something like 70% of his pension. So he delayed his treatment for reasons that are completely outside his power of controlling. This is not one country. I think patients can move from Texas to Boston without losing anything. They simply go where they think they would be treated the best possible way. So there are a lot of things to be done. And I think we must force the two administrations, European administration and national administration, to do the things that we want as citizens and as a patients to do. One network is the internet, I understand that. But another network that could be done and be as strong as the internet is if you build a strong patients' internet that would be present in all countries and in all levels of health systems.
Thank you, Kostas. Does someone want to respond or add to it? Go ahead, Mihai.
Maybe to add rather than to respond, I think I would say, just to use the example of the HTA regulation, that this challenge across multiple, let's say, entities across 27 member states, I think we see that as well, as Kostas was mentioning, in healthcare systems that are decentralized. So it's not a European problem, it's a decentralization problem, maybe, if it's a problem or not to be discussed. But it's the same kind of dynamics that we see in Italy, in Spain, in Sweden, for example, where the regions reach different decisions at different points in time. And I think it's an issue also with the HTA regulation, and it's a philosophical challenge. A uniform decision is rigid. There's no way around it. However, a flexible decision leads to inequality, or not inequalities, but leads to differences between how decision was made and the time it was made. So those are, for me, roughly the two extremes between, and there are, I think, at different points in time, we say that we prefer the centralized decision, and at different points in time, we say that we want the flexibility at national or at local level. So these are, for me, the two, let's say, not necessarily extremes, but the barriers within which we need to navigate European healthcare policy. As Kostas was mentioning, we don't have a common health policy, maybe for good reasons, but there are days when it makes sense and there are days when it doesn't. So it's really just about figuring out what we want.
So I just want to play devil's advocate. Actually, we do have a European health policy. We do have a European health policy. It's just that people are not aware that we do have a European, and I think Penilla probably wants to add after that.
Yeah.
So we do have a European health policy, and we do have national health policies. Aligning them is a matter of actors and institutions, and also the question arises, and this was a very good example that you mentioned, for cross-border healthcare directive and so on, do people actually know what they're entitled to if they go to another jurisdiction? I can tell you, because of what Mihai just mentioned, we are in rare disease, we're already seeing people shifting to jurisdictions that they think they will get better access because of what's happening with HTA regulation. But just to make it a little bit more specific, specifically for cancer or for lung, cancer is a very complex disease. It doesn't stand alone. It needs supporting systems, it needs carers, it needs integrated care, it needs trust starting at a very early level with general practitioners. And we actually have the first sort of data that it's showing for the first time, and I will talk about it later on, that before we had rural areas, remote and, compromised in terms of access. Now in some cases we're seeing faster access to treatment from rural areas because there is a person actually acting for the patient to gain access. And in places where solo practices are gone, there's nobody being an agent for the patient. But specifically for the EU PRISM, we are discussing treatments, and we have discussed a little bit of screening. We have not discussed the fact that lung is probably the modality with the biggest innovation coming through, and probably because of pollution and other things, climate, biggest incidents going up. But we have not discussed diagnostic means for targeted therapies and so on. And there you start to see new acts, like the Biotech Act. I do not know how many of you are aware of this. And I would like at this point to say there are two things happening. Innovation discussions are a lot and a little bit skewed. So I think there's a place for the patient to discuss this in relation to EU health policy and how it links to innovation. And the second one, what Professor Syrigos described in Belgium will be happening anyway, irrespective of how a patient functions, because the health systems are under pressure. So we're seeing in all the countries, from biopsies or from diagnosis to treatment, times increasing, and follow-ups getting lost, and so on. So that, at the moment, the way the systems are structured, that it's bound to become a biggest challenge and a more costly challenge for systems. So there's an extra risk there, even in countries with a good system, even in countries with a lot of prevention, early diagnosis and so on. There's a lot of risk of seeing people fall through, let's say, the gaps. Yeah, thanks.
May I?
Go ahead.
You were talking about Star Wars. Well, there are 27 stars in the EU flag. But I think you were a bit out of space there. Sorry. in a way, because you were talking about the insurance systems, and the insurance system is a national issue that cannot be implied actually by EU right now. I wouldn't say it will last forever. But as it is right now, it's a difficulty for many patients cross-border that they don't have access to specialist healthcare. Because you can have immediate healthcare everywhere in the union. You know this blue insurance card that you should have? You probably have that if you have traveled here. I hope so. Don't get sick otherwise. It's so much easier when you have this blue card. But actually, also to reflect on the fact that EU was created as a peace project, and it has been a very strong resistance from the European countries to act within the healthcare area together. So I think it's a main and very good progress that we are finally, after so many years in the union, that we are trying at least to have common health policies in so many areas. And the Euro-Speaking Cancer Plan, created in 2019, has really shown also to many countries that we are able to work together. we are able to create a good cancer care. But if we don't accept these plans or strategies or would like to work from them, of course, it will still be inequalities all over Europe. That's my strong opinion, that we need also to take our individual or national issues, put them a bit aside for the common good. If it's good for one patient in Sweden, why shouldn't it be good for one other person in Greece or Denmark or wherever? I think sometimes we also need to keep up what is happening. So I would say also that it's not only for the patients to create some kind of, from under, below, to blow something up also to create knowledge. It's also for the healthcare professionals to keep up what is happening. It's not only that we think that healthcare professionals or politicians can work just in silos. They need to work together. And if there are wise politicians or other kind of policymakers, of course they are listening to all parts of this. Industry, patients, healthcare professionals, whoever are in this system for what we're talking about now, cancer care. But the social insurance systems is a problem today, and we are not mentioning that problem enough, I would say, because also in cancer we have this, maybe you've heard about it, the right to be forgotten, that are fighting for cancer patients to actually have their rights, to get bank loans, to keep their houses, to get new houses, not to be, questioned and say, okay, maybe you fall ill again, so that's why we cannot give you any loans or trust you with this position or whatever. So we still have so many things to do, but we need to do it together. Otherwise, it's useless, I would say.
Thank you, Penilla. And I think Elena wanted to answer. Sorry, I'm just going to jump to her.
Just two quick comments. The first one is I do wear many hats. So within the European Medicines Agency, we have two groups, physicians, healthcare professionals, and doctors, patients. And I'm sitting in the doctors, physicians, cross-talking with the patients group. The very well-informed people in that group are not necessarily representative of all healthcare professionals, but they're still exhausted. You cannot remove the burden, of information building systems. Should be a national competency, absolutely, but it shouldn't be the healthcare professionals that have to do all of this, interpret legislation, inform the patient. There should be other mechanisms there. So that's one. We're trying to do it, but even informing within the specialty, let's say for public health or for oncology, ESMO is there and so on, it's very, very difficult. It's a massive task. That's one. The second one is the moment you commodify care, Europe is in a very privileged position in many ways in terms of access. And by Europe, I mean the broader region, including the United Kingdom and so on. Perhaps not wider European region in other member states, more to the east. But having said that, health is commodified, and you do have out-of-pocket payments. If the insurers would want to collaborate, it could be quite easy because you have still in place strong national systems. So to avoid cherry-picking for insurance, to avoid catastrophic payments, still there is a little tiny window of opportunity for the countries to act. And then, of course, they could build trust in the citizens. They could build social cohesion, which could be even better than defense policy, let's say. But okay, that's very subjective. Thanks.
Thank you. Kostas, I believe you had a comment.
I quite like this discussion because it's so typical every time. People in the field blame the administrations because they don't know what is going on every day. And administrative and politicians blame technocrats because they don't obey. This is so typical. What my idea of unifying system is a way far what now exists in European Union. Let's see the drug issue. all European oncologists know what is good for the patient. There are good clinical practice guidelines. There is ESMO. We know what we should do. This is clear. There is no doubt. If you ask somebody from Hungary, Greece, Ireland, Poland, the guidelines are the same. We all respect them and we all would like to follow them. Fine. Let's see how drugs are approved in the European Union. Very simple. One organization, one authority, as long as EMA approves the drug, this is approved everywhere in Europe. Fine. Who benefits from that? Definitely not the patients. Definitely not the physicians. But somebody benefits. Because then the industry has to apply only once, has to go through only one procedure, and then it is approved all over Europe. Then why not being reimbursed all over Europe? 90% of the drugs that are approved over the last 2 years in oncology are not reimbursed in most of the 27 countries. Now, there are 32 drugs in oncology, not in lung cancer oncology, that are approved by EMA, but are not reimbursed in Greece. I don't know in other countries, but in Greece are 32. Why scientific approval and reimbursement are two different procedures? Why they are not one procedure taking place at the same time through the same organization? Can you imagine the power? How many millions did you say is European Union? Can you imagine the power of negotiation of this number against the industry? But no, we leave Greece with 10 millions to negotiate with MSD, Roche, AstraZeneca, who they don't care about Greece. Never sell drugs in Greece. You know that India has owners of airplanes, more than the population of Greece. So if I were CEO of AstraZeneca or MSD, my priority would be these people in India who have plane, would not be Greece. But if approval and reimbursement was the same all over Europe, our negotiation power was much stronger, the prices we would get were much better, and our patients all over Europe would have the same treatment. It's as simple as that.
Thank you. I'm just going to jump to Mihai. Sorry. Because he is. I'm just going to jump to Mihai to see if he's got any thoughts to share, because he is our market access specialist. He'll know a bit more about the HTA than anyone else in the room.
No, I mean, I appreciate the impassioned speech and, of course, the desire behind it. I think it's clear that we all share it. But the challenge is, okay, at what price?
The cheapest possible.
Yeah, would that presumably be, what if the cheapest possible price is higher than the one that is currently in Greece? How do we bridge that gap? I think this is the challenge. Of course, I mean, Penilla was whispering that it's a national competency. I think obviously that's an easy escape for me to say that it's a national competency, but it's also a national challenge, and it's also a challenge from an economic and willingness and ability to pay challenge, because, like I said, I was trying to say earlier, when it's one decision, it's much more rigid. And I think what the current, and it's certainly imperfect, the current approach also from FPA members is that it enables companies to provide, let's say, a more tailored approach to access and pricing. It doesn't work all the time. I'm with you here, of course, but it takes two to tango. It takes also the company, and it also takes the member states to agree on an access and on a pricing and reimbursement system. And what I'm trying to say is that maybe this is where we have, of course, a variation in prices across member states. Some are higher, some are lower. If you try to uniformize them, what guarantee do we have that is it going to be average? Is it going to be the highest? Is it going to be the lowest? and what happens afterwards. So you have one decision first. How does the system, or how do the actors in the system react to that decision for the decision n+1? I think, and this is a more personal opinion, when we had the Pfizer contract negotiations for the COVID-19 vaccines, great example, but it took 3-4 days. I think it was November 2021. It took less than a week for Germany to announce that they had reached another side agreement to purchase extra doses. So it's all great that we want one single decision until we don't agree with it, and then we want our own separate decision.
Elena, you seem very active to add something.
Several points. I worked in R&D, and I'm very proud of what we did for NSCLC. So I was in the tepotinib team, which was rejected by NICE in 2021. And then it was accepted in 2022, so over a period of a few months, because of course there were no comparators. And we knew it was working for a large part of the population in 2015, 2016, and we were very excited about it. So 10 years on, to know there's no access can get very frustrating. Now I'm saying this because, yeah, maybe there are guidelines, and maybe what benefits someone in Sweden benefits somebody in Greece. But if you don't have appropriate testing and knowledge of population level information, you cannot assume that. And the payers have very different questions than the regulators. And by the way, HTA is not a reimbursement mechanism. It is a mechanism to inform who would benefit more and who would be harmed less. And if indeed we had the same practice across member states clinically, then we wouldn't have the member states sending 20 to 30 different PICOs and standards of care when it's time to do assessment at the central level. So at the moment, what we're seeing is, despite guidelines, is highly divergent practice, not only in lung or oncology, but across very different modalities. And for cancer, because you get first, second, third, fourth, fifth line of treatment, things get even more complex. If you're lucky enough to know, primary and to know where you started with, thinking of sarcoma and lung from family experiences. So it's, in principle, it sounds very nice and tidy, but in reality, it's very complex. Also, in terms of innovation, it's very complex because the moment you commodify health, health is commodified in our society, for better or for worse, speaking as an academic. So the money that goes into investment, it's the same money that goes into any portfolio. I mean, if we looked with my students during COVID to see who was investing in vaccine development, there were the same hedge funds that were investing in Philip Morris and in Browning, which for public health, of course, guns and tobacco are. So the money, you need money to do innovation. Either you need a completely different funding mechanism and innovation mechanism from member states in Europe and globally, or you need a very different way of managing innovation, because at the moment, many of you may have heard of Trump and most favored nation and what's happening with pricing. We will see, I think, soon enough, to your example. But most of the money that's pouring into innovation is not necessarily European money. And I think this is becoming starkly visible. Well, most of the money that's coming in for drugs, certainly for diagnostics. Diagnostic modalities have not emerged. Primary research has been in Europe, then Asia or NGS or California, wherever. So it's very tricky to say that if we have one policy and we negotiate one price, we will ensure access. So tricky topic. And I think this is where perhaps the economists may diverge from the clinicians, and the policymakers, of course, want to ensure that they will be able to provide access not in a single category of treatment. So let's say that you have universal access for lung and universal access for cancer, but you don't have, I don't know, anything for rare diseases. That's a societal decision. It's not there. So we're going back to governance and deliberation and actually capturing the values and the preferences of the people in the society. That is not happening at the moment for health in any country, including the most well-developed, civilized, and so on. Yeah, sorry.
No, thank you, Elena. And I think what's really shown in this conversation is how complicated it is. It's not just a straight, direct approach. We're going to jump to questions in a minute, but Kostas has said he's got 2 words to share.
I know it is complicated. I know it has many options. I'm not prepared to give it up yet, because it has not to do with pricing and reimbursement. it's all the pharmaceutical issue that should be addressed. You know that few months ago, FDA of United States rejected a very useful drug in multiple myeloma solely on the basis that it was not adequately evaluated in United States patients. Do you know the percentage of patients from the states that participated in the studies? 25%. And they considered it's not enough. So if European Union forces the industry to invest in research, basic research done in Europe, clinical trial done in Europe, then otherwise not even consider the drug for evaluation. If things change in a more wide way, then the complicated system becomes even more complicated but provides solutions.
Fair enough. No more 2 words. We need to get a chat with questions because I really would like everyone to have a chance. Sarah, should we go to Slido or should we go with raised hands?
Busy on Slido, and we're very happy about that. You've upvoted lots of questions. If I may add one little spice to the conversation, there is also, we haven't brought it up yet, the Critical Medicines Act and the idea of voluntary joint procurement for critical medicines, including many oncology medicines. So there are some conversations and mechanisms toward ensuring adequate pricing and fair pricing and improved access. So just throwing that as a note of hopeful optimism that there are mechanisms in the works for this. All right, let us go to Slido. So top question here. So how do you see the investment in cancer care in the EU after this political cycle? Tough question. Do you think it will continue or be engulfed by cardio and innovative therapies, etc.? Essentially, it's a bit of a turf war between different health initiatives. How do we ensure, though they overlap and they all intersect, but yeah.
Well, people have been worried that when this budget period is ending and how it will be with the European Cancer Plan and the work with Horizon, of course, has provided so many projects, and projects should just be started and end, but we need also to have a continuation of what the results have been. So we in the Cancer Mission Board has at least a prognosis of it should be continued in some way. We don't know the figures, but of course the work with cancer will continue, and I think Elisabetta was mentioned that also yesterday. But since it was also approved a safety heart plan, a CVD plan in December last year, we also see the connections between cancer and cardiovascular disease. And I've been some kind of informal advisor also for this plan because I'm very interested in cardio-oncology. Myself, I was diagnosed with a severe heart failure because of cancer treatment many years ago. So I think it's really, really important to see the connections between these two biggest killers in Europe, in the world. But I just want to say this. Don't put one disease area against another. Because people are... I meet so many people all the time that have, multiple diseases. So we should not take that thought in our head at all. It's so important that these two areas also connect with the others.
Yeah, absolutely.
So when we have a better treatment or better diagnostic tools for cancer, for example, of course it will benefit all the others as well. So I think we are on a good way with both these areas and as well as others.
Thank you very much for that answer. I'm going to take the second question and direct it to you, Kostas. I think it's going to be stirring the pot a little bit. So I'm hearing you say that you have this unified vision of what the EU could be. So the next most upvoted question is, how can we enforce synergy at European level if it doesn't even exist at a local level?
It's very simple, work both ways, work not only at European level but at local level as well, and all patients' organizations should have representatives, active representatives in all member states so that it works both ways.
Simpler than I thought. I'll take it. Any other answers? Any other takers for that question? Okay. Okay. So we've done this question, we've done that one. I think another one that would be interesting perhaps for you and Mihai. So with the influence that the US has on clinical trials, on treatment availability and cost, what should the EU stop, start, and continue to do to change this across Europe?
US is already behind. You should see what's happening in phase 1 in China. China is exploding.
The new latest player.
This is, Europe at the moment is not market 1 or 2 or 3, so it's negotiating power. It's nothing like it was 10 or 15 years ago. Clinical trials have been down in the US over the past few years. We are celebrating many more clinical trials. We need double or triple that, perhaps. And I think it's time also to discuss what we do in the real world setting.
Mm-hmm.
And the power of Europe could be there because there's lots of stuff coming with the electronic health record, AI tools also, and of course the HDS. But in terms of investment, you also need to invest in clinical trial infrastructure. Yes, legislation has changed. We've seen many countries, I think to some extent, including my home country, change a few things to make things easier. That's not enough, and that is not incentive or support for patients to participate in. And then, of course, there are accessibility challenges. There is a very big European project for underserved and underrepresented populations ready, an IHI project, and I'm a scientific advisor there. And when we went in the meeting, there was the question to the audience, what is the biggest reason for which you see cancer patients leaving trials? And very few of us responded, and it had to do with how much they may be suffering because of pain, because of adverse events, because of many other things. This is just really something that is still care and is not discussed a lot and is not provided from anywhere. So to circle back to the previous parts, yes, we have a cardiovascular plan, we have a cancer mission plan. How they cross-talk and how they translate to integrated care is not there. It could be and it should be, but it's not yet there. And there is space for national actors and space for patients as well. But somehow that information has to cascade down. 30, 40, 50, 200 pages of cardiovascular plan, which, by the way, mentions liver disease somewhere in there, but nowhere does it link obesity to cardiovascular health and liver disease explicitly, does not necessarily help integrate in terms of meaningful practices for member states for outcomes.
Thank you very much for that
I
comprehensive
think
answer.
this question leads to a very slippery road. I am a clinical trials guy. I developed my reputation, my CV, my income from clinical trials, but in the European Union, we had 120 days approval, and we are very proud that we went it down to 80 days. And in Greece is even less. I have been in February in China, and they are proud that now the approval from day 0 is 5 weeks. Is this a competition or what? Why 5 weeks? 5 days. But who will be the victim of that? The patients. Either we take seriously the clinical trials and we decide and we approve and we give authorization for a clinical trials or not. We should not compete who has the lowest period. I think 1 month or 2 months is a very reasonable way to go through all the procedures. We should not embark on this fight with China. I remind you that China did that now because previously they used unethical methods for their clinical trial, and this is why we did not accept their results. Now they have found another way to circumvent this problem. We should not embark in this fight.
Elena?
I'm not advocating that. I'm talking about investment. It's billions. So that's infrastructure to conduct trials. That's not a matter of expediting 4, 5, or 25 days.
And to conduct multi-country trials, which is even more investment.
You can, absolutely. You have other mechanisms in Europe. We're seeing other things. And of course, I think we're discussing very different animals. A phase 3 trial is very nice. I'm discussing early phase 1 for discovery and so on. So there, to boost, you need investment from member states and from the industry and so on.
In truth, you need investment throughout the whole thing. Mihai, anything you want to add to this? Can you just leave it on? Yeah.
Okay, sorry about that. So what I wanted to say, just to add to this issue in terms of both clinical trial, but also ecosystem and so on and so forth, I think, and as far as I understand the numbers, it's a relative change in position, not an absolute change in position. I think clinical trial activity in Europe has increased. It's just the challenge that it has increased more elsewhere. And I think, as Elena was saying, we all welcome more clinical trial activity regardless of where it is. There's, of course, and this is going to be an interesting thing to observe, the acceptability of the data by regulators across the region. I think that was an interesting example from Kostas with the FDA and the 25% Americans. I think it's only going to get more challenging. But what I wanted to say with all of this is that it's a relative decline rather than an absolute decline, and whether we like it or not, we are in the fight, or let's not call it a fight, we are in the competition with other regions of the world. And it's just the nature of life. This is, unfortunately, we just have to run faster to stand still, unfortunately. But that is the very nature of competition with other regions, that we have to do better. And I know this is not a popular statement to make, is that this comes also, we have to do better also when it comes to investment. And investment is both into supply side measures, but also into demand side measures. And by that I mean, of course, also spending more on healthcare overall and on medicines as well, but also on healthcare, because whether we like it or not, maybe the economic growth is not as great as we would like in Europe, but the population growth is, the aging of the population is, the burden of diseases increases and everything. And we have to, at some point, just add or just invest more in order to tackle all of these challenges.
Thank you very much for that answer. I'd like to now shift to our most upvoted question. So a bit of a spicy one again. What can we as patients do if the national health policy makers do not want to follow the EU guidelines? Does the European Commission impose any penalties on the countries?
I wish.
You heard it here first. Cancer Mission Board wishes.
No, is this recorded? Yes, it is.
Yes. It's recorded and it's on the record, yeah.
No, but actually, when I have the opportunity to travel around to different countries and meet all these people, and also governments governmental officials and so on, I think it's interesting, to see how eager some countries really are, because they have seen maybe the cancer inequalities registry, and see they are falling behind, for their patients, and can see that, okay, we need to step up here to actually give at least a better way for patients better pathway for patients to have access to treatment or access to care overall. Sometimes, so no penalties, but it is discussed, between different also DGs in Brussels. The Cancer Mission, as Hugo mentioned yesterday, is a collaboration between the RDD, Research and Development Innovation, and also the DG Santé, which is about health. So I think it's really crucial that countries, really want to be active. If they have ministers that they don't want to be part of this, of course it affects both the healthcare professionals as well as patients and also the life science industry, because clinical trials must be supported, as we heard here as well. So yes, there are a lot of discussions going on for especially a few areas maybe in Europe, but no penalties, but discussions, because that's the way the European Union works normally.
Okay, well, thank you for that answer, Kostas.
I think there is a lot of space for patients' groups there, because local governments are not complying with European Union recommendations or laws. They fight back legally in their country, and usually they win, at least in Greece. It takes time, and individual patients cannot do that. but patients, advocates can do that very well.
I think the question, though, is about EU guidelines, and I'm assuming this refers to EU treatment guidelines more so than regulations or directives.
But treatment guidelines is, as Kostas mentioned, is maybe from ESMO or something like that. But you have these screening recommendations, for example, that
Which are not binding.
They are not binding, but they are strong recommendations, very carefully researched and developed. So I think every country should be adapting them. And if they haven't, I mean, I come from Sweden. It's not adapted yet with lung cancer screening. There are pilot projects going on, but not adapted yet. So there still are some countries that are working with their screening recommendations overall, I would say. There are 6 recommendations for screening, and well, you can pick any of them, and you can see in the cancer inequality strategies, which I recommend actually to see where your country is heading.
All right, thank you very much. So I'm going to call it a day for the Q&A portion of this panel, but I'll hand it over to our moderator to wrap up with one last question for our panelists and to wrap it up before the next part of our agenda. Thank you all.
Thank you guys so much, and thank you for so many questions. We can see it's been a very riveting subject, a lot of different opinions, so at least we're getting people thinking about how complicated this landscape is. I thought we could at least go through one last question for each speaker, and we have a lot of different patient groups here, different sizes, different capacity of doing advocacy lobbying. What's the one piece of advice you would give them to get more involved in policy, to start actually being able to advocate? Like, where should they start? Elena, do you want to go first? And we can
Yes, I can start. It's the same advice I give to my students. It's very basic. It's about reading. Read more, know your rights. It starts, I mean, there are legal texts there in obscure language, but now in every language. So understanding what the new policies are and how they're going to be implemented. The HTA regulation, which once again is not reimbursement, is in place. It affects everyone, and there is space. Almost not a single country has good mechanisms for involving patients in the national decision making. As for cancer screening, not even 10 countries have implemented some of the 6. So there is a lot of space there, and knowing, what is best practice, knowing what the legislate, then gives you different kind of voice. And of course, networks. And I think to some extent you are already doing it, because you are here and we are here, and we are all, I think, rather passionate people in this panel and in this room. There is another aspect, which is, it could be very tricky, I think. I don't think we have enough, we don't give enough visibility to patients in academia. We've started introducing more patients in lecturing, so we have now few patients coming in for HTA in good practice. But there are people that are coming with stronger, let's say, advocacy background from other modalities to cancer. HIV was very strong, as you may know or not know, for obvious reasons in the 80s, and also because they did not have access, and they're becoming again because they're losing access to, in some European countries, to lenacapavir, to preventive drugs. So also crosstalk with other patients and find commonalities. It's a bigger voice, it's a stronger voice. So I think knowledge is the key, and I think also somehow talking more with academia and healthcare professionals in specific mechanisms. Because another thing that we're seeing very often, and I think this you may know, we sometimes see in terms of representation and legitimacy in representation the same 5-10 patients in the last 10 years. So I know there is stigma, and I know it's difficult, and I know it's different to talk from outside. I mean, as I said, I've found myself in the strange position of being a carer, and it's a very different perspective. But you have to, nobody else can step into that role other than the patient and the carer. So it doesn't matter what I say or what other clinicians may say and so on. You need actually to be there and to speak up more. And to do that, you need mechanisms. So there's no way around about it. So, which is slow, by the way.
Thank you, Elena. Mihai, any closing remarks on how they can start?
So I would say keep doing what you're doing. I think what I've noticed also in the last years, but I also know from people that have been doing this for a lot longer, I think it's a great thing to notice the professionalization of the patient advocacy voice compared to maybe 10, 20, 30 years ago. I think part or maybe a lot of the pressure, the political pressure on access also comes from better information sharing in patient groups, because it's normal for people to get together and to realize that maybe somebody else has better conditions in their country and they have to ask themselves, then why not in mine? I think it's an absolutely important political role for patient organizations to play in sharing the information across countries, and then also doing this sort of maybe more uplifting and cross-breeding of ideas in terms of how to do things better in each country, because we have to, I mean, we heard it also today, we have to do better across the board, and there is certainly something somebody somewhere can do better, and I think it's an important role for patient organizations to play. So that's my summary, is to keep doing what you're doing.
Thank you. Kostas.
I would say demand to be there everywhere that important decisions are taking. Be there early, demand to be listened, not just a symbolical presence, which is the case most of the time. Request, demand that your opinion is in the results and in the outcome. So in order to be that, your opinion must be sound, must be scientific, must be based on knowledge. So scientists and physicians are recruited by NHS to treat patients, are recruited by universities to teach new doctors, are recruited by industry. Why not by you? So that your opinion is valid and everybody will be forced to listen to it. And you will be surprised how much we are willing to listen important and useful opinions and proposals from you. In ASCO plenary session last year was presented a trial, a huge trial in colorectal cancer. It was not a new drug. It was not something innovative. It was a drug, a trial, very complicated, designed with the participations of patients. And the outcomes of the trial were set by the patients. And the difference in the quality of life, respecting the overall survival, was huge. This is what I mean, important interventions. And the oncologist listened to the patients and now changed completely the treatment of colorectal cancer. Small changes that made the huge difference in the quality of life of the patients. So you have a role. Ask for your role. Not be happy with a symbolical presence.
Thank you. Kostas and Penilla, any last final remarks?
Well, I strongly believe in crossover, working together aspects or results rather. I'm having also an initiative in Sweden that we are calling Focus Patient, and we are really working crossover diagnosis and working with all areas in healthcare and life science. And I think what we're trying also to do in the Cancer Mission Board is to listen to all the voices where we are out, like I'm here today and yesterday, also to listen what you are doing and in your area of cancer. But we also need to have this crossover organizational exchange and also between different areas of healthcare and life science. Because you had this, what was it called? The town hall yesterday. So, of course, we need each other. And we need to have the discussion between each other also to understand our different angles of all these pieces of cancers that we are working with. And I also encourage you to have policy training. When you're meeting different policy makers, please be prepared. I remember when I was an MP that some people had asked for a meeting, and when they arrived, they had a list of things. and really a big list of things that I was also, advised to take care of and do something. That's the most common thing. Do something, and it's not that easy because also policymakers or other, in politics and so on, they need to have the knowledge and understanding as well. So you need to take care of their time when you meet them, and then it's also for you to have this policy training as well as for them to take care of your knowledge. Thank you so much.
And that's actually a brilliant place to end, because tomorrow there is... Sorry, we have no more time for questions. We're very late. I'm very sorry. But tomorrow we're actually doing, for the members, a bit of a taster session on how to engage with MPs. So if you're interested in what she was mentioning of empowering yourself, please come to my session. But thank you guys so much for an amazing conversation. I really think the questions were amazing. And I'm just going to pass to Sarah for what's next.
Yeah, so everyone just stay seated for one moment. So first off, big thank you for your engagement, for your passion, and for kicking off the day with such insights. So it is now time for our coffee break, so chance to caffeinate, stretch your legs. The coffee is in the same rooms as yesterday, the blues and breakaway rooms. Small little tidbit, a little icebreaker fun. On the paper cups, you'll notice that there's little stickers like this. And they each match a theme. So you may use these as icebreakers to kick off a conversation with your fellow conference attendees. So we ask that you please be back and seated for 10:30 a.m. sharp, because our next session is on AI and data, and we can't wait for it. Happy caffeination.